So let's move on. So the reason why we're talking to Adrian here is because Adrian wrote this superb review. There's a lot of reviews out there. Essentially, the review covered T1 colon cancers and the prognostic and predictive factors within those T1 colon cancers. And there's a lot of reviews out there, but the depth that you took it to, I think, does take this review to another level. So it's just very, very comprehensive. And so it's something that I think should be on every GI pathologist's desk. So Adrian is going to talk, you're going to show us a case and talk us through it and tell us what you do when you encounter one of these.
No, that's fine. I must at this stage acknowledge my excellent trainee, Dr. Emma Norton, who of course was my co-author.
Oh, that's right.
And we really worked well together to create it. And a lot of the fact that it's in such depth is due to her work as well as mine, actually. So it was a very good writing team. So what we have here is a resection, and you can see the non-neoplastic mucosa here, and then you can obviously see the submucosa here and the muscularis propria here. And then we should be able to see, if I zoom in, hope you can see that I'm zooming in now, we have here the submucosa, and we have some very irregularly shaped and placed glands infiltrating the submucosa. There is in fact a little bit of mucin production over here as well. There's an area here that's probably some adenomatous change. If I zoom out slightly, you can see adenomatous change elsewhere that's merging with adenocarcinoma here as well, in fact. So this tumour appears well to moderately differentiated. There's a lot of inflammation present. Sometimes that makes you cautious if you're looking at a case where the differential diagnosis is with epithelial misplacement, but I'm sure this one shows, even at low to medium power, sufficient architectural atypia for this to be a diagnosis of carcinoma.
Yeah, this is probably a pretty obvious one, isn't it? I mean, I don't think anyone should have problems with this one. The desmoplasia,
No.
I particularly like the angulation of the glands. Even though the border is somewhat pushing, but there are little nests of going out.
Yes, exactly. And you zoom in, you can see some little tiny islands of epithelial cells as well, such as this area.
Right, yeah. I particularly like those little nests of cells that don't form glands. I occasionally use a keratin stain to uncover occasional single cells trickling. Have you used keratin to?
Yeah, sometimes, and we get quite a few cases in the pathology board, in fact, where people have used keratin. You've just got to be a bit careful, because sometimes when there's significant acute inflammation, you can get what we call epithelial dissociation, breaking up of even a benign, deeply situated, misplaced adenomatous gland because of inflammation. And that's not what's happening here.
Right.
So you just got to be a little bit careful, I think, if something could still be epithelial misplacement. But in this one, we're happy it's carcinoma. Again, there, some rather irregular glands. But another interesting feature here is this case, of course, has some lymphatic invasion just here,
wow.
which can be highlighted with immunohistochemistry if you need to, the CD31 or a CD34, or of course the D240 if it was lymphatic. And this patient did actually have a regional lymph node metastasis as well.
Oh, very cool.
And that's a very good example, a clear example of lymphovascular invasion.
But if I stop you there, I think in many instances we'll look at it and say, could this or could this not be? So what tips do you have for folks in terms of defining lymphatic invasion? And then the next question would naturally be, how do immunostains help? And I'm sure there are pitfalls to the interpretation of those endothelial cell stains.
Yeah, there are. I mean, I suppose there's two things. The first is if there's a lot of retraction artifact around the actual carcinoma cells, then of course you might get a rim surrounding carcinoma cells, even if they're not actually in a vessel. That can happen, but in this case, we're not really seeing retraction, particularly in the carcinoma itself. if you're not sure, certainly doing those immunostains can help you to be sure that you're looking at tumour that's within a vascular space. So lymphatic or a small blood vessel. The other situation that we're just learning about, actually, we've seen several instances in the pathology board, is vascular intrusion. Now, that's not the case here, but we found that even if you have epithelial misplacement in an adenoma with no adenocarcinoma, you can sometimes get what some people call a toothpasting effect, presumably occurring mainly secondary to torsion and trauma of the polyp, where benign adenomatous epithelium can get squeezed into a vessel even if there isn't adenocarcinoma present. So that can be quite difficult. It sometimes occurs into larger veins with an obvious muscular wall.
Oh, wow.
And I think there, the key thing is to look at the lesion as a whole, because if there's nothing else that's telling you something looks like carcinoma, if everything looks like misplacement, then probably what you're dealing with is vascular intrusion. And indeed, sometimes within vascular intrusion, you can even get lamina propria as well as malignant epithelium. So that's a phenomenon we're just learning about, really, but I'm sure it exists.
Seen a picture of this phenomenon that you're describing. It's really scary. So one of the things I frequently tell my trainees is that, well, I have a very high threshold for accepting something as vascular invasion. So if, as you said, if there's a lot of retraction around, I'm not particularly persuaded. I demand an endothelial cell layer or something, some sort of flattened epithelium focally. And I demand that there's no major retraction elsewhere, and that it isn't a push, and that it is attached to the endothelium at some point. I hate using the word equivocal because I just don't know what our surgeons supposed to do with that term, right? I mean, I've been trained not to try and stay away from uncertainty, so I go one way or the other.